And welcome to everyone who is generous enough to attend. This is our technical healthcare briefing, so it's for only the most hardcore healthcare care focused, wonky fiscal policy followers, because there is a lot to cover today. Healthcare is always at the center of the state budget. This year is no exception, maybe especially so. And so I'm going to cover as many of the key healthcare issues as I possibly can. We're not going to get to everything. I'm happy to take questions about what I missed at the end. And I'm going to shoot to speak for 45 minutes here. Generally, the structure of this presentation is I'm going to talk about sort of the background, big picture, where is Medicaid, New York State. Then I'm going to talk about coverage issues in the budget, provider funding, some specific policy topics, and then end with a little note on the federal context for all of this. And as I talk, please use the Q&A feature in the chat to ask questions. I'm probably going to hold off on answering questions until the end, just because we have a lot to get through, but we will go back through and answer questions. So, to begin, I want to start with just sort of grounding us in where Medicaid is in New York State, how it's growing and changing, and how important it is for our healthcare system. So, one of the most basic questions you could ask is how many people are on Medicaid in New York State? It's a surprisingly complex question, and sometimes you'll hear people say that almost half of New Yorkers are on Medicaid or whatever. It's not quite that big, but it is large. These figures, which are up to date as of November 2025, show that about 5.1 million people in New York State get their sort of primary health insurance through Medicaid. The Essential Plan, a separate program, covers another 1.7 million people. So if you add those two numbers up, you get about 6.9 million people, or about more than a third of the state, 34% of the state, getting their primary health insurance through New York State administered programs. There are also many folks who are on Medicare but use Medicaid as well, either for long-term care or for to help pay Medicare premiums and copays through the Medicare Savings Program. And so it's a massive part of New York State's healthcare infrastructure. Here I just break down how different groups fall into that. So the state often cites a headline Medicaid enrollment figure of 6.8 million. That corresponds to, 5.1 million people on Medicaid or CHIP as their main source of insurance, another million or so people on the Medicare Savings Program, and then a small but sort of high cost group of around 500,000 who use it for various kinds of long-term supports and services. Another 1.7 million are on the Essential Plan, which is not Medicaid, but is subject to separate federal appropriation. The Medicaid program is funded basically half and half between the state and the federal government, and we can see that the sort of total Medicaid budget for fiscal year 2026, that's the one we're currently in, is about $111 billion. Of that, the 52% is funded by the federal government and the other 48% by the state, and to a lesser extent by counties and New York City, which pay a capped $9 billion-ish portion of the total price. The Medicaid budget is growing and is projected to grow in fiscal year 2027, but not that quickly. The governor in her executive budget 30-day amendment said that Medicaid was due to grow at 13.4% year over year from fiscal year 26 to 27. I would say that figure is a little bit misleading because it incorporates two sources of growth that shouldn't really be counted in the baseline. Technical sort of wash payments associated with the state's MCO tax, which account for about $1.4 billion in fiscal year 27 spending, but are really just sort of wash payments back and forth between the MCOs and the state and don't really impact overall spending. And then a further almost $2.6 billion that's associated with the increasingly unlikely possibility that the state may have to assume a very large group of people, about 500,000 Aliasa immigrants, onto state-funded Medicaid. That it looks now, knock on wood, like that won't actually have to happen. And even if it does happen, it's a new population. It shouldn't be counted towards baseline growth. And so if you eliminate those two sources of confusion, you get a much more modest 3.6% Medicaid projected growth rate, which, as we'll see, is largely a result of increases in reimbursement rates to providers rather than utilization or enrollment. Because, as we'll see, both utilization and enrollment are down in New York State Medicaid. Um, Medicaid, you can think of the Medicaid budget, even though it covers those 5.1 million people, and most of them receive primary health care, like sort of major medical health insurance. And then it covers a much smaller group of 500,000 people who receive long-term care. In terms of the enrollment, it's mostly a health insurance program with a little bit of LTSS on the side. But in terms of the budget of Medicaid, it's actually closer to half and half. So mainstream managed care, which is sort of the healthcare part of Medicaid, and then accounts for about half of spending, and then various forms of long-term care account for about the other half. And so I'm going to talk about trends in each of those programs one by one here. So in terms of mainstream Medicaid enrollment, this is the big sort of health insurance program for low-income people that is what people think about when they think about Medicaid, right? Health insurance for people who are low income and can't get it from an employer. That program before the pandemic was sort of hovering around 4.5 million. And then during the pandemic, it really spiked because people lost their job during the pandemic. And then because federal rules forbid states from disenrolling anyone from Medicaid. But you can see in this graph that it's actually back down to where it was before the pandemic. So it came down quite sharply in 2023 and 2024, and now it's back to around 4.5 million and declining. The other sort of big driver of costs in the Medicaid program is managed long-term care. So managed long-term care is the main program through which New Yorkers who are older or have a disability and need help with sort of activities of daily living, like bathing, dressing, stuff like that, receive home care so that they can sort of live independently in their homes. In New York, that service is mostly delivered through managed long-term care through private insurance companies. And so by looking at MLTC enrollment, you can get a read on sort of home care growth and utilization. And what we see here is that MLTC was growing quite rapidly from the end of the pandemic or the public health emergency rather to 2024. But in the past year, the past 16 months, that enrollment growth has ended and actually reversed. You can see that enrollment is a little bit down in the end of 2025 from this graph. And the reason for that is really, really clearly shown on this graph. So this is a graph of MLTC enrollment. Sorry, I should say, since this is the technical briefing, my MLTC enrollment figure includes partial cap managed long-term care. It also includes Medicaid Advantage Plus, which is sort of the duals managed care program, and then also PACE. So this is sort of combined enrollment in those three programs. Within that, MLTC is falling, partial cap MLTC is falling even more rapidly, and MAP is growing. But sort of combining all those programs, you get this graph. And so to figure out why this market enrollment trend change happened, I zoomed in on just the past 2 years and looked at sort of annualized monthly growth for 2024 and 2025 in those. And this graph shows really, really unambiguously that the big factor in changing enrollment trends there was the CDPAP transition. So, as most of the folks on this call probably know, the state dramatically changed how it was running its CDPAP program for home care in the beginning of calendar year 2025, and it had a very, very rocky transition from a system with multiple fiscal intermediaries to a single fiscal intermediary. And you can see that right there, the enrollment growth completely stops right in January 2025. That's the big change. There's a further change in September, the 380L rule, which basically sort of raises a further barrier to home care enrollment. That may also be a factor, but I think we need a few more months of data to determine whether that is a factor or whether this is just sort of some noise in the data. I want to emphasize the fiscal impact of that CDPAP FI transition, right? So any change in MLTC enrollment trends is enormously impactful fiscally because someone enrolling in MLTC costs the state about $55,000 a year, all funds. And so this change in enrollment is itself enough to generate an enormous amount of sort of all funds savings in the Medicaid program, right? And so I just sort of penciled out, like, if you look at where enrollment trends were headed as of 2024 versus where we've ended up, you can see that there's something like $4.6 billion in all funds savings, $2.3 billion in state share savings. There's been some debate. The governor has claimed $1.2 billion in state share savings associated with CDPAP, and legislators have wondered where that's coming from. My read is that the vast majority of that savings is generated by enrollment decline, meaning fewer people are on home care, and that's sort of how we're saving money. There's been some suggestion that savings comes from, rooting out fraud in the program. The executive has claimed that. I don't see any evidence of that whatsoever. From my perspective, it's just an enrollment decline. And so there's a question of, is this a good thing? I personally worry quite a bit about it, that fewer people are accessing home care who might need it. And then also, is it a sustainable thing? Is the state going to sort of continue to save money here? On both fronts, I'm a little skeptical. The concerns about sustainability of savings have to do with the FI transition and sort of making it harder to stay enrolled in CDPAP has caused a huge number of people to shift to agency home care, which is more expensive per dollar. That hasn't hit the state budget yet because in the first instance it's covered by the MCOs, but eventually we'll have to see MLTC premium rates go up to correspond to that more expensive model of care. There's another question about whether the sort of program growth that was formerly generated by FIs under the old system will just sort of be generated again by agencies. And then there's a question about whether we're sort of squeezing the balloon of home care demand, whether people are seeking out home care through AAAs or through the NHTD program, which the governor has said is experiencing a lot of growth and has capped. Are we really addressing issues here? My view is that these savings are unlikely to be sustained, and we're unlikely to sort of guarantee home care, which should be a policy goal for us, unless we shift away from the sort of managed care model that we have and pursue a reform like the Home Care Savings and Reinvestment Act. But I'll just say this transition and this sort of shift in enrollment creates an enormous amount of fiscal room for the state. Like Medicaid is growing, underlying Medicaid spending growth is much slower, and that has allowed the executive budget and the one houses to invest a huge amount of money in provider rates. Um, and so, those are sort of the utilization and enrollment trends. Now, I want to talk about insurance coverage and the impacts of federal policy changes there. So, as we all know, in last summer, the Republicans in Congress and Trump passed a bill that really dramatically cut healthcare funding from the federal government, and in particular, really targeted lawfully present immigrants, of whom New York is lucky to have a lot, really slashing funding and access for healthcare for that population. The bill also imposed work requirements on Medicaid, which are a huge administrative barrier to staying on Medicaid, even if you qualify, which most people do, which FPI estimates may cause 800,000 people to lose coverage. And so there are some other cuts coming down the pipeline, but I just want to say between essential plan cuts and Medicaid work requirements, we're looking at a loss of insurance coverage of over 1 million New Yorkers over the next 2 years. This graph sort of shows what that would mean in terms of our insurance coverage rate, that we would really lose most of the progress we've made in the past 20 years, 15 years in keeping New Yorkers covered. It's a really frightening prospect. The most urgent of those cuts is to the essential plan. The essential plan covers 1.8 million people. It's fully federally funded with $14.6 billion in federal money. About less than half, 40% of the people on the essential plan are lawfully present immigrants, and HR 1 just sort of totally eliminates funding for lawfully present immigrants in the program, which works out to be a more than 50% budget cut for the program. And so the program in its current form isn't sort of sustainable. We're going to have to figure out how to change it and put new money into it or cut people off it or both in order to sort of continue to fund it. The governor's budget proposal, so in response to those federal cuts, the governor proposed to change the program by reducing eligibility for it. This is the green sort of wing of the flow chart you see on this slide. Reduce eligibility threshold from 250% of the poverty line, where it is now, to 200%. That would, on the one hand, allow the state to sustain the program for the 1.3 million people on the essential plan who are under 200% of the poverty line. but it would mean that the folks who are between 200 and 250% of the poverty line would lose coverage this coming July. Um, and that's nearly 500,000 people. That's 470,000 people who, under the governor's plan, are expected to lose coverage in this coming July. And so that's obviously really, really concerning. This whole trajectory requires federal approval, and if we don't get federal approval, we get an even worse outcome where potentially the essential plan could go away entirely. This week and last week, we got some indications that we are likely to get federal approval. It's not 100%, but it seems increasingly likely. So we're likely in this sort of more likely green scenario. But that doesn't mean we're out of the woods. It means actually 500,000 people are set to lose health insurance in July. Um, and so where we're at with this now is we uh, we have received federal approval to move to the thing we want to do, but not to stop doing the thing we're currently doing. So we've received approval of our 1331 program we want to do, but we haven't received approval to suspend the 1332 program that we're currently doing. Approval for that was just made public last week, so we're all sort of digesting the news. But it does look like we're going to get essential plan approval, which really accents the urgency of doing something to cover those 470,000 folks. Um, so what do the executive budget and the one houses do about coverage? Unfortunately, they both do very, very little. So the executive budget and the assembly would allow 470,000 EP enrollees to lose coverage in July and a further 800,000 to lose coverage beginning in January due to work requirements. The Senate is a little bit better. It would do the same. Both of those groups would lose coverage, but it does provide some money for navigators and legal support for people due to lose coverage. And it has some language directing DOH to sort of develop a plan to maintain coverage as much as possible, but there's no money associated with it. So broadly, both the executive and the one house budgets really sort of contemplate the scenario displayed in this graph where we see 1 million people lose health insurance coverage. It's very disappointing. We don't have to accept this though, and especially because we just received federal approval for our essential plan change. The federal approval actually frees up $2.4 billion in the executive budget because it allows us to access more money and cover low-income immigrants in a different way. So we get $2.4 billion. Using just that new funding that we just got access to through the federal approval, we could actually cover everyone. We could provide permanent state-funded alternative coverage for the EP 200 to 250 population. That's the 470,000. And we could also provide grace period coverage for Medicaid work requirements populations, giving them 3 to 6 months to get their paperwork in order so they don't lose coverage just due to bureaucratic obstacles. And we could do both of those things for less than $2.4 billion. So that given that we now are getting a little more certainty about federal policy, this should really, really be the focus of budget negotiations for the next 2 weeks. Unfortunately, the focus of the executive and one house budgets so far appears not to have been on coverage, but on funding for providers, both provider rates and safety net hospital funding. Both really, really important issues, but also a little bit frustrating to see them focused on to the exclusion of maintaining coverage. I'm going to talk about what the executive and the one houses do on sort of provider rates, hospitals, but also nursing homes and other kinds of providers. And then I'm going to talk more specifically about hospital safety net funding. So just to sort of set us up and put us in context for the hospital funding conversation, Medicaid rates paid to hospitals are much, much lower than commercial and Medicare rates. And the result is if you're trying to run a hospital that treats mostly Medicaid enrollees or a large share of Medicaid enrollees, it's really hard to keep the doors open. During the Cuomo administration, for about a decade, hospital rates were basically flat. That led to a sort of de facto state policy where we fund safety net hospitals not via the rates, but via non-rate supplemental payments. Now, that has changed a little bit in the past three budgets. Each of those budgets gave a significant rate increase to hospitals. And we're seeing that dynamic repeated. We're seeing sort of the Hochul administration support steady increases in Medicaid rates to hospitals. And these are all funds numbers. Despite that, despite those rate increases, we've also had to spend more on safety net hospitals, which we'll return to in a moment. Um, and so, hospital and nursing home funding in this year's executive budget. So, as background, last year's enacted budget funded a bunch of hospital rates through MCO tax revenues, so through this sort of special mechanism we were using to get more federal money. And that special mechanism was actually eliminated by HR 1. And so there was a question going into this budget cycle of if the funding source is eliminated, are the rates themselves going to be eliminated? And the answer was very much no. The executive budget came in and backfilled lost MCO tax revenue to the tune of 750 million, state share 1.5 billion, all funds to both preserve the rate increases from last year and also add room for additional rate increases on top of that. And I emphasize the word backfill because the governor has repeatedly said we can't backfill federal cuts, and she's used that as an excuse not to protect people's Medicaid and essential plan coverage. For provider rates, though, it did turn out to be possible for the state to backfill. The backfill was entire. And you can kind of see what's happening with provider funding through the sort of several years through the various proposals. So the every column on this table is sort of poorly labeled, but every column on this table represents a fiscal year 2027 number. So the first column is back when we passed the last budget, what were we expecting to do in fiscal year 27? And you can see we were expecting to invest about $916 million state share into provider rates, largely hospitals and nursing homes, not exclusively. There was some funding for physicians, FQHCs, other stuff, but mostly through hospitals and nursing homes. Now, the fiscal year 27 executive budget sort of looks at that last budget and says, no, we can spend a heck of a lot more. And what it does specifically is it creates a pot of money, $750 million, that is reserved for provider rates, but is not sort of allocated to specific providers. And so it preserves hospital and nursing home rates, it preserves most of the rate increases, but then adds more room. So at the bottom, you can see there's about 600 million more dollars for rate increases. The one houses deal with this in different ways. So the Senate actually goes ahead and allocates a bunch of that 750 million to hospitals, nursing homes, also home health, various other provider pots of money. The Assembly doesn't allocate that money, it just adds more money. So it adds another $550 million onto provider rates on top of that 750 or 450 on top of the 750, sorry. So you can see all three, the executive, the Senate, and especially the Assembly, are really, really generous with provider rates this year, especially for hospitals. Um, the legislature also increases capital rates for hospitals and nursing homes. So even outside of these investments, there's even more money. Um, and so, the no backfill narrative about what we can do on healthcare funding doesn't seem to apply to provider rates, just to coverage, which is disappointing. I want to talk about safety net hospital support, which is a really, really critical issue in this budget. So when people lose health insurance, when there are federal cuts, that impacts safety net hospitals that treat Medicare and Medicaid patients, really especially. The state funds hospitals very largely through safety net funding outside of the regular Medicaid reimbursement rate. I tried to do a back of the envelope calculation, and I believe that the sort of total state Medicaid bill for funding hospitals works out to be about two-thirds in the rates and one-third in supplemental payments to safety net hospitals of various kinds. And and so it's important to understand that the safety net funding is really an important structural feature of maintaining the hospital system we have. I do a quick breakdown here of the various safety net programs and their fiscal year 26 funding levels. We'll share the slide so you can look at this in more detail, but basically in fiscal year 26, our largest safety net program was DPT, which increases Medicaid rates for safety nets, and there was also a laundry list of other programs. And those programs are what is displayed in this graph of sort of finance. This is a graph from the executive budget of safety net support. And we can see um, it funding increased a whole bunch after the pandemic. In fiscal year 27, it looks like it's going to be lower, but as we'll talk about, that has to do with the VAPAP cut in the executive budget that's likely to be reversed. And so, in fact, we're looking at sort of flat funding for safety net hospitals in this budget. Um, the executive budget cuts 500 million from one safety net program from VAPAP, which is sort of the program of last resort to provide discretionary funding to hospitals that are really at risk of closure. So the executive budget cuts VAPAP from $800 million a year to 300 million. That would be really catastrophic if it happened, but I think that there's a little bit of a symbolic dance going on here between the executive and the legislature. Every year, the executive threatens this cut and the legislature reverses it. The one houses both reverse it. I think it's unlikely to happen, but I think it's more the executive sort of sending the message that she doesn't feel like the level of safety net hospital funding we're doing is sustainable on the long term. There's a slight increase in safety net transformation program funding in the executive from 300 to 330. Safety net transformation program that's operating support for hospitals that are also getting capital support from the state to sort of restructure themselves in ways that the state believes will be more financially sustainable. That's part of the funding stream behind, for instance, the Health and Hospitals takeover of Maimonides, and is sort of a program that the executive loves more than VAPAP because the goal is to sort of restructure these hospitals for good or for ill in a way that makes them less costly for the state to maintain. But really, on safety nets, we're looking at a pretty status quo budget, unlike with provider rates, where there are significant new investments. This is just sort of flat funded. And in the longer term, there are really significant federal threats to safety nets, including DPT, which is $4.5 billion, which is the largest source of safety net funding in the state, and also 1115 funding for downstate hospitals through the Global Budget Initiative are both likely to see cuts over the next couple of years. And so there's a real concern there. I want to. I'm aiming to finish talking at you by 12:45, so I'm going to move really quickly through this. There are a number of policy issues in the budget, including the independent dispute resolution process in New York. So this is New York's No Surprises Act that it was passed in. I'm sorry, not 2018, but 2015. Disregard the slide there. Um, the way this works is if a patient receives a surprise bill from an out-of-network provider, meaning this is the kind of situation where you go to a hospital that's in network to get surgery, but like the anesthesiologist is out of network, so you're surprised. In New York, consumers are protected. They don't have to pay extra for that. Instead, the provider and the insurer sort of have an argument about it and eat the costs. And the sort of who pays how much between the provider and the insurer goes to the independent dispute resolution process. New York's IDR process has huge problems. Mostly that IDR resolutions tend to happen at a really, really high rate. So insurance companies pay a lot and providers get paid a lot through IDR. And then also, Medicaid is included in the IDR process, which causes rates to be excessively high for Medicaid, right? Like usually Medicaid pays a relatively low rate, but if it's in IDR, it pays an exceptionally high, even higher than commercial rate. And so this is a challenge. Medicaid overpays. A business model is emerging where providers stay out of network to receive high IDR payments. And also, NISHIP overpays for related reasons. So the IDR in the executive budget, there's a really aggressive effort to sort of change how this process works and make it less friendly to providers who might be sort of abusing the process and lower cost for the insurer. And so all told, this is these sort of reforms, carving Medicaid out of IDR, changing NISHIP's relationship to IDR, and also just lowering the sort of target for negotiated prices would save the state about $60 million. And would also lower private insurance costs because ultimately, if the insurer is paying an inflated cost, it sort of it goes back into the premium. Both the Senate and the Assembly basically totally reject these proposals. There's another set of issues around the ways the state subsidizes malpractice insurance through the medical indemnity fund and excess medical malpractice. The exec proposes sort of reforming these programs in a way that would raise costs for providers potentially and lower costs for the state. The one houses reject those proposals. The exec also proposes limiting some access within Medicaid to biomarker testing and applied behavioral analysis therapy. Those would both save money, and the executive rejects both of those proposals. So there's a real theme emerging here where across a whole bunch of issue areas, the executive is a little bit more interested in restraining funding in a way that is unfriendly to providers, and the one houses are interested in sort of restoring that funding in a way that is more friendly to providers. And overall, even outside rates, that corresponds to about $250 million in extra Medicaid spending that the one houses deliver. I think it speaks to a pattern where wherever you land on any of these individual issues, there's a concern that it's concerning that policymakers are really listening to the biomarker industry lobbyists more so than to the folks set to lose essential plan coverage. And so generally, we should take another look at these budgets and ask, what are we doing to prioritize coverage? I want to just touch on at the end a sort of late breaking in the past couple weeks issue that's sort of on the horizon of state budget Medicaid, which is the federal government has accused New York State of running a fraud-ridden Medicaid program and has threatened to really dramatically cut federal funding for Medicaid for whole program areas due to the alleged fraud that it alleges. This sort of broke into public view on March 3rd when CMS, the federal government, sent New York a letter saying there was a whole bunch of fraud in our personal care, home health, adult daycare, non-emergency medical transportation, and behavioral psychotherapy programs. The federal government actually really does not present any evidence of widespread or even relatively small spread fraud other than citing, fraud that has already been caught. But it sort of uses the size of these programs and how big they are to imply that they're full of fraud. And basically, its strategy is this really unprecedented effort to slash federal Medicaid matching funds for whole program areas. This is unprecedented, right? So historically, the federal government has sometimes denied federal matching for a state program that isn't doesn't qualify as a Medicaid program. If the state is doing something with Medicaid money that isn't really Medicaid eligible, or if we discover like some specific instance of fraud, right? Like if it turns out that some specific nursing home was defrauding the state Medicaid program, the federal government will say, well, we're not paying the federal match on that fraudulent activity. What the Trump administration is trying to do is a much, much more radical and more dangerous and illegal thing, which is to say, look, we think your whole home care program has so much fraud and you're doing so little to sort of police the fraud that we're going to just eliminate funding for your home care program. Um, Now, to be clear, is there fraud in Medicaid? Of course, there's fraud in every state program, right? Like there's, it's not achievable to run a program with 0% fraud. But it's important to emphasize that the federal government is not correct that high New York State Medicaid spending is due to fraud, right? New York State Medicaid spending is high because we run a national model home care program that provides home care as an entitlement without wait lists. And doesn't require people to impoverish themselves before accessing home care and doesn't require them to be on a wait list for years like happens in some states. And that's a policy decision we've made that in my view, is a really good one. Not that the New York State home care program is without its problems, but I think it is really, really good that we've guaranteed that older and disabled people can live independently. And I would just say that the political context here on this sort of federal challenge to these programs is really that the federal government is trying to do through executive action what it was not able to do through Congress, which is to really dramatically cut the part of Medicaid that supports older and disabled people by providing LTSS. And so, it's not sort of clear where this is going to go. It's very likely to be litigated. But I would say the federal threat here is clearly illegal, and we should just all say, as healthcare advocates, like we're, with all its warts and with all the time we spend fighting over it amongst ourselves, we're actually very proud of what New York State has done in terms of expanding access to home care. And so I'll just end on this note of coverage because I think it's so crucial. 1 million New Yorkers are set to lose insurance over the next 2 years under all three of the budget proposals, with beginning with 470,000 people starting this July. It's really, really urgent that the legislature address this, that the governor address this, and we have funding available to address it because we have federal, it looks likely that we'll get federal approval now. And so that's really the most urgent question in this state budget is what happens with that. And now I will stop there, just 2 minutes over, and I'm very happy to start taking questions, and I'm sure there are a few. Let me just look into. I'll just start with the questions in the Q&A and then start calling people out. But it's actually really helpful if you put questions in the Q&A just because it's a larger group than I expected, so maybe easier. So Mansoor asks, why would MLTC enrollment go down due to moving to a single statewide FI? It's a great question. I think there are a couple of factors. One is that the transition to a single statewide FI was extremely, extremely rocky. People, in some instances, lost services or weren't paid. And so some people may have fallen through the cracks of the program. I think in an ongoing sense, now that there's been some degree of stabilization in the program, a big part of the dynamic is that the old system with a whole bunch of the FIs advertised aggressively, raised awareness of the program, supported people in enrolling in the program. And PPL is contractually banned from advertising the program and sort of recruiting people into it. And so I think whether you think it's a good thing or a bad thing, I think the big factor there is likely that fewer people are being made aware of the program. So and let's see, Christopher asks about one issue that I didn't cover, which is the 212 million Rural Health Transformation Fund. HR1, the bill last summer, cut healthcare in a way that's really likely to impact rural hospitals, and so to persuade some rural Congress people to vote against their constituents' interests and fund that and vote for that bill. They included a fund specifically for rural hospitals to try to preserve them for a few years. New York got $212 million in Rural Health Transformation Fund programs, funds which it has to spend over the next couple of years. I I'm not immediately able to say exactly how those funds are going to be spent. The thing I would just emphasize is that in the context of hospital funding, $212 million is not a huge amount of money. And so we should remain really concerned about rural hospitals in the next several years. Um, Emil Watkins asks, are there any accountability mechanisms for providers who are currently getting high Medicaid reimbursement through IDR by staying out of network? You know, to my knowledge, no one has alleged that the Medicaid billers in the IDR process are breaking the rules. It's just that the IDR process, as currently set up, is quite friendly to providers, especially relative to Medicaid rates. And so I think that the issue here is not so much a lack of oversight as that the rules were poorly written sort of from the beginning, and as you know, some actors have figured out that the rules are poorly written. There's always a risk that sort of finding finding loopholes becomes sort of a business model. So I'll treat that as read. Um, an anonymous attendee says that our governor didn't do New York any favors by demonizing CDPAP. In my opinion, she gets the blame for this new federal scrutiny. I really could not agree more. I think it's been incredibly unhelpful that in order to sort of build support for the CDPAP transition, the executive has repeatedly sort of said that CDPAP is fraud or a racket. And, to some extent, what I would say is that based on her public comments, it seems to me that the governor doesn't really think it's legitimate to for the state Medicaid program to pay family caregivers, and thinks that that older and disabled people should rely on their friends and family to provide that care for free, and that family members should be willing to, quit their job, lose their income in order to do that for free. And when she said it's a racket, I think that's kind of what she meant. But the truth is that New York State has made a policy decision. We're not alone in that. A lot of states, including Washington, Oregon, California, and Massachusetts, also make that decision to allow family caregivers to provide home care because we think it offers freedom, flexibility, independence, and shifts us away from an old model where we were really depending on free female labor to provide the long-term care in our state. And that's a legitimate use of state funds. It really has not been helpful to imply otherwise. Um, an anonymous attendee asks about IDR and what FPI thinks about the NISHIP and the Medicaid components of the proposal. So, yeah, we're supportive or I personally am supportive of both of sort of the three planks of the IDR process. One would be to not to have IDR mediation be sort of targeted at a reasonable payment rate at the 50th percentile of allowed costs instead of the 80th percentile of sort of asking price. And then basically what the governor's proposal does is carve NISHIP into that reformed program, because then NISHIP would be able to pay reasonable rates for surprise bills in that program. And then to carve Medicaid out entirely, because Medicaid is really a special case. It reimburses lower than commercial rates for a reason. It should keep doing that. I think those are all sensible policy. I think could we sort of play around with the numbers on where IDR negotiated settlements should be? Absolutely. And I hope the budget results in a sensible reform rather than the kind of deadlock we're in now, because I think the status quo is really clearly not great. Um, let's see. Mark um, Mark Hannay asks, is there any evidence that people falling out of CDPAP may be ending up in nursing homes? I am sure that in individual cases that has happened. That is, I think the state very irresponsibly did an incredibly rapid CDPAP transition with an incredibly vulnerable population. And I think there's a real concern that folks lost access to services and may have ended up in nursing homes or hospitals because of that. I will say that in the aggregate, many policymakers tend to make an argument for home care in terms of saying it'll sort of save money by preventing nursing home care. Um, That again happens in individual cases, but I think we in New York have to acknowledge we run a really big home care program, and it has not overall saved money, right, so dramatically reducing nursing home expenditures. I think the reason for that is that a lot of people, if they don't have access to paid home care, they make do, they rely on the charity of their family members, they will do anything to stay out of a nursing home. And so home care and nursing homes aren't sort of perfect substitutes for each other. It's not like every person who leaves home care goes to a nursing home. And that means overall it's costly for the state to offer paid Medicaid home care. It's just, in my view, exactly the kind of guarantee of independence and dignity that the state should be spending money on. So I'll just sort of say that as a kind of nuanced answer. Um, Someone asks, could safety net hospitals negotiate better reimbursement rates with Medicaid without relying on the state to put in money to cover the gap? I think it's a really good question. Um, Right now, we're in a sort of weird equilibrium with safety net hospital funding where Medicaid rates are low enough that like you can't run a hospital that stays in business just on Medicaid rates. That has to do both with the absolute rate levels and also with inequities in terms of how different services are funded. So inpatient psych, obstetrics, uh, those kinds of services that safety net hospitals provide a lot of are not funded as well as higher tech, types of medicine like surgery and so forth. And so there's an inequity both in the overall rate and also in the specific service mix. And right now, Medicaid rates are low, and we sort of balance it out by providing a huge amount of annual supplemental funding. The question is, should we really just raise Medicaid rates high enough that we don't need all of this supplemental funding? I'm ambivalent on that question. I think that right now, raising Medicaid rates that much would be extremely, extremely costly to the point where it's politically not realistic. And a lot of the money would go to hospitals that don't necessarily need it, right? That have a 20% Medicaid share, but also treat a lot of other folks. And so I think there is an argument for saying, like, Medicaid rates should come up gradually, but also, like, it's perfectly appropriate for the state to offer supplemental payments and make sure that there's broad access to hospital care using more targeted payments. I would like to see the state reconsider how it funds those specific lines of service, like inpatient psych and obstetrics, that do need higher reimbursement rates. The thing I would just emphasize is that we've made policy choices that mean that high Medicaid hospitals are always going to need supplemental payments. The supplemental payments are not evidence that a hospital is badly run or low quality or not providing good care. The supplemental payments are required because we've made decisions on reimbursement rates as we have. And so, I think sometimes policymakers like to talk about it as though ideally, like, hospitals should just survive on the rates and we're doing them a special favor when we give them supplemental payments. It's important to understand that the supplemental payments are not going anywhere, that they're a structural feature of or should not go anywhere, right? That they're a structural feature permanently of how we fund hospital care in New York. Um, and Margaret asks, is the increased funding for Safety Net and other hospitals designed to enable them to treat the newly uninsured rather than preserve insurance coverage? Well, I mean, there is no specific Safety Net funding that is increasing, right? Like, we're basically looking at status quo Safety Net funding. Provider rate increases should provide a little bit of room for safety net hospitals to cover the newly uninsured. but if you really wanted to make sure to insulate safety net hospitals, I think you would direct funding more into the supplemental programs and less into overall rate increases. The other thing I'd say in response to this question, right, is like the state has two choices when 1 million people are threatened with loss of health insurance. It can either say, we're going to spend some money to cover those people, or it can say, we're going to, we know those people will still show up to the hospital, whether they're insured or not, when they have a medical emergency. We're going to just sort of provide like funding to those hospitals to stay open and treat them without being reimbursed because the folks are uninsured. And the first way where we protect insurance is the right way to handle this problem, right? Like we want people to have health insurance so they can get primary care, so they can stay on top of their chronic conditions. We don't want a healthcare system where uninsured people end up in the emergency room and then, the hospital needs a bailout to fund all the free care that it's providing. And so if that is the intention to say instead of people keeping people insured, we're just going to fund hospitals to treat the uninsured, then that's a really poor policy choice. Um, an anonymous attendee says, what impact do you think that the hospitals at home proposal will have on both hospitals and the home care program, in particular CHHAs? That is a great question. Since you're logged in as an anonymous attendee, if you could shoot me an email about that question, I would love to talk about it because I have wondered, but I unfortunately do not have a good read on how all of that interacts with each other. And more broadly, if folks have specific questions I haven't gotten to, I'm just going to stick my email in the chat and am very, very happy to talk offline about other issues. Because we are 3 minutes over, so I do think that we should call it an afternoon. But I would be delighted. This was really fun for me. I don't usually get to talk in such gnarly detail about New York State's healthcare programs, and I would love to talk more. I know there are many important things I didn't get to, such as the Primary Care Investment Act, the prospects of the New York Health Act, many other good initiatives. So I would love to hear more and talk more with all of you about that.